everyone. I am Christine Poitou, endocrinologist for adults in Paris and part of the French National Reference Center coordinated by Maïté Taubert. Together with Maïté, we will chair this symposium today. It is really a great pleasure to welcome you for this Endo-ERN thematic symposium organized by the Group 5, Growth and Obesity. I would like to thank you being here. I see that 33 attendees are here connected, but I think many attendees are registered, so it's really great. The theme today we have chosen is the clinical management of transition of care in Prader Willi Syndrome. As you can see on the screen, we have today a very exciting program with several experts for Prader Willi Syndrome, but also the point of view of professionals, parents, and patients themselves. The objective is really to share a global view of these complex diseases. After each presentation, you will have the possibility to post your questions in the questions box, and we will relay them with Maïté. So I leave now the floor to Maïté. We will start with an overview of the syndrome as a model of hypothalamic obesity. Maïté, the floor is yours.
Thank you. Thank you, Christine, for the introduction, and thank you. We are very happy to, on behalf of the MTG5 Growth and Obesity group, to make this symposium on transition. So I will start with the pediatric aspects, but first an introduction of Prader Willi syndrome, to be sure that we are talking about the same idea. With my disclosures here. To start with, the first is saying again that Prader Willi syndrome is a neurodevelopmental genetic disorder due to loss of expression of paternal inherited maternal imprinted alleles in the chromosome 15 in the region Q11, Q13. The new things is now that the subtypes, the genetic subtypes are different, because now we have almost half of the persons presenting with maternal disomy and 50 of them presenting with paternal deletion. So probably that is due to the increased maternal age and paternal age at birth of the child with Prader Willi syndrome. We recently wrote a paper with Charlotte Hoybray, who is presented here today with us, that PWS is as a neurodevelopmental trajectory with 3 dimensions: nutritional, endocrine, and metabolic, and behavior. So this disease starts with at birth with hypotonia, sucking difficulties, which resembles to anorexia, and then switch to excessive weight gain, which came first, and then hyperphagia leading to obesity. And hyperphagia, I'm going to explain, is almost food addiction, if we agree on this term. Then we have the behavioral features. At birth, babies suffer for poor parent-infant interaction, poor social skills, and then during the development, they presented as adults with intellectual disability, learning disabilities, poor social skills, and emotional dysregulation. And I can say in between, we observe an endocrine and metabolic dysfunction, which also follows a specific trajectory, mainly hypothalamic pituitary deficits, also precocious adrenarche and precocious puberty. Almost it is not frequent, it can appear, and we can understand why. Many of the patients, when they are obese, may present with diabetes. And I want to just to mention here that there are also oxytocin and ghrelin dysfunction, which is not the classical hypothalamic pituitary deficits. What is characteristic of the pediatric approach is that we now made early diagnosis. In France, the diagnosis is made before 1 month of life, at 18 days, and that offers a window of opportunity, not only to implement multidisciplinary and adapt care, but also to have the possibility to implement treatment and drug treatment, as we are doing right now. As I mentioned previously, we focus and explain how Prader Willi syndrome is a model to understand and treat hypothalamic dysfunction. And we want to explain with this figure that hypothalamus dysfunction and also impaired development explain the whole feature of Prader Willi syndrome. Starting from the left inside here, hypothalamic explain the endocrine dysfunction and also metabolic disorder. We don't know exactly what are the mechanisms, but probably hypothalamic also drive metabolic issues. Hypothalamic, of course, is the center of the regulating of appetite. So the dysfunction of hypothalamus here explain eating disorders observed in Prader Willi syndrome with impaired appetite regulation, involving hyperphagia and deficit of satiety. And what we see here is that the oxytocin pathway is abnormal, but also the action of ghrelin in the hypothalamus is also impaired. And that's probably explain the switch from anorexia to hyperphagia. So the nutritional trajectory of this specific disease. And indeed, hypothalamic dysfunction also are linked with behavior troubles, particularly with emotion regulation issues and troubles, addiction, social disabilities. And dysautonomia is really included in the hypothalamic dysfunction because of the interrelationships and close relationships between hypothalamus and regulation of dysautonomia. So they can present temperature dysregulation, hydroelectrolytic disorder, gastrointestinal problems, and cardiovascular dysregulation. And what do we know now about the genes on this chromosomal region that may explain the feature? What we are learning now is that we can explain compulsive-like behavior with this gene here, the 2GCP5 and the CYF1P1, which are really involved in the compulsive-like behavior. So that is really interesting also to see that certain genes are involved in the behavior regulation. And also, this gene here is involved in palatable food preference, which is a characteristic of patients with Prader Willi syndrome. And regarding these genes here, major 2 gene and SNOR116, which is one of the major genes of the region, we also explain the endocrine dysfunction, is the oxytocin impairment and also maturation of hypothalamic hormones and gastric hormones such as ghrelin. And of course, the next disease is involved in the regulation of respiratory function and circadian rhythm. So now we are learning more and more, although we don't know everything, the role of the genes in this specific region. And we also learn more and more the abnormal neurocircuitries engaged in the hedonic and physiological control of feeding behavior. It is now demonstrated that there is a damping of orexigenic and anorexigenic neurons in the hypothalamus, with hyperactivation of neurocircuits involved in appetite control and motivation. So it is really important to understand that, to understand the disease, and to try to implement the adapt care for these patients and the family. And of course, remember that PWS is of course an endocrine disease. We also have endocrine endocrine interactions and neurotransmitter alteration that I'm not going to detail here. Therefore, this very complex disease with more than 10 organ dysfunction mentioned here is a very complex disease to cope with. for the patients, for the family, and also for the carers. And of course, it's require a comprehensive care. First, endocrine dysfunction, that is the most important care to implement soon after birth, to try to prevent obesity, to try to screen and treat endocrine dysfunction, particularly growth hormone deficiency. I have written here diabetes because for the transition period, diabetes is a very important issue to screen and to treat. Hypogonadism, that is to be treated also since birth. Cryptorchidism, which is related to hypogonadism. Premature or aggressive adrenarche, that in Prader Willi syndrome starts as soon as 3-4 years of age. So we have to pay cautious to that and treat that and screen it. Try to treat hypothyroidism, which is present from 20 to 80% of the cases, depending on the publication. And regarding central adrenal insufficiency, it's a very low frequency in pediatric and in adults. And then we have in pediatric to evaluate, to screen, and to prevent some comorbidities, and of course to treat them. So we on the continuum of oral skills dysfunction at birth, they present dysphagia and GI problem that need to be evaluated and treated. They also present sleep apnea, sleeping disorders with narcolepsy and cataplexy, epilepsy more rarely, scoliosis, which is very frequent, about 80%, ophthalmological problem, dental issues that are less frequent now because of the lifestyle improvement, skin picking, dysautonomia. And then we have the re-educations, that speech and language problems, oral skill and communication issues, cognitive evaluation to try to adapt the schooling of these children, try to cope with learning deficits, and of course having continuous evaluation of behavior and psychiatric issues, starting very early in life, not of course at birth, but from 4 to 5 years. It's interesting to implement what we call here in our team preventive psychotherapy. And of course we have, and it's the most important thing I want to say today, that we have to evaluate, evaluate it's not the right word, but to try to know who is this family and how can this family cope with the patient, with the child. So we have to evaluate family and the carers around the family to promote schooling, orientation, and socialization. And what we have seen in many years, we are treating a patient with Prader Willi syndrome in our team, is that we have to target as soon as possible the frailty families who will have more difficulties than others to cope with such a complex disease. And just regarding the voice of the families and the parents, they put first the hyperphagia. Although in childhood we don't we don't care with the hyperphagia because it's arriving slowly, and until the adolescence we don't have that much issues with hyperphagia, but parents put that in the first place. And so, and we can understand because this hyperphagia is very close to addictive disorder. And particularly addictive disorder, as we all know, are more present in the transition period in adolescence. So I just want to make a note on that, and that probably the problem will come with the transition period. And I will skip that. And also there is, beside the hyperphagia and the behavior which are difficult, they also developed in this particular period other addictions, smoking, for instance, in the adolescence, rarely alcohol, but they also developed and worsened global impulsivity, disruptive behavior, and thinking rigidity, which we know are also the characteristic of adolescents, with or without Prader Willi syndrome. So interestingly, again, listening to parents and family, and it's something which is very important for Berit, and she will explain that thereafter. We can see that hyperphagia is increasing with age, and it's more important here in the transition period. And what we see is that the burden, so the difficulties with the family is correlated with the hyperphagia score with the HQ-CT. And interestingly, during this period, food seeking is not the first thing that's reported with the family, but the first thing is behavioral issues, oppositional behavior, anxiety, temper tantrums, and are the first. And then when they are older, almost 20, the food seeking is the first one chosen by the family when they are asked. So at this period, probably, and very interesting to have a psychiatrist with us today, the behavior problems are probably the most important in this transition period. So in pediatric, we have to cope with neonates, children, children about 7 to 10, and then adolescents, right, like this person. And so it is difficult also, but necessary, to try to organize very early the transition. Talk to parents, talk with the child, saying that they will have to be cared by other team than the pediatric team, and that is important for them. So, and the transition period from pediatric to adult healthcare is even more challenging in adolescents with PWS, because they are, really, they have a great attachment to the team, to their doctors, to the dietitian, and so it is not that easy to change the team. So the first meeting that we had in trying to put together the transition in Prader Willi syndrome was in Vienna in 2015 in a meeting, which in this paper we talked about our experience on Prader Willi syndrome. And more recently, a team in Paris, led by Christine Poitou, published the impact of transitional care on endocrine and anthropometric parameters in Prader Willi syndrome. And what I want to just summarize, because she will explain that a little bit more, that the organized pediatric care is the first step. And the second one is to share knowledge and questions with the adult team, to get motivation for the adult team, and then give motivations to patients and families to cope with the new team. And finally, we need to make, at the end of adolescence, a comprehensive re-evaluation at completion of growth, endocrine and metabolic issues, comorbidities, behavioral issues, re-education, learning and schooling and socialization of this patient. We propose to make that in a pediatric setting. And then, of course, and that's the reason it is in the middle of the slide, that we have to take into account, firstly, the project of the adolescent, because the adolescent can explain and want to explain what he wants to do. And the family approach and the implication of the family is also very important. And then, of course, the adult endocrinologist with the psychiatrist and the whole team is of great importance. It is a continuum. So the discussions between the pediatric and adult teams is not only with a person, but is a permanent discussion to have more insight in the disease. So I just put this presentation of growth hormone evaluation just to mention how we do in France. So we don't stop systematically growth hormone. If the patient refuses to stop, we continue, although we don't have the marketing authorization, but we have, as a reference center, we have some rights. Of course, we have to give the reasons. But if the GH peak at GH testing is very low, we continue growth hormone treatment. And if it's not the case, and if the person wants to stop, because half of the cases they want to stop treatment, so we implement a follow-up regarding BMI, regarding the body composition, and if it's worsened, we propose to the patient to resume growth hormone treatment at the dose, decreasing dose from adolescent to adult dose. So it is not recommendation, and we will have a presentation from Charlotte Hoybay on this point, but that's the way that we do in France, because we rely on the very interesting studies here performed by the Netherlands team, showing that interrupting treatment at completion of growth has very bad consequences on body composition, IGF-1, and metabolic issues. And resuming growth hormone treatment completely rescue the worsening of the situation. And now they have more than 3 years following these young adults, and the benefits from growth hormone treatment in those adolescents who received growth hormone treatment during childhood are very important. What we have in adolescents, these adolescent population display many psychiatric issues that are not very well known by the adult endocrine team. That was a problem that we faced for many years in France, but now it's improving. We have more and more psychiatrists interested in the disease, but we still have a lot of work to do. So these particular issue are some difficulties that we still have to face with the care of adolescents with Prader Willi syndrome. And we have to emphasize that there is a genotype, subtype differences with more than 60% of patients with disomy with a neuroleptic treatment compared to 23% in the patients with deletion. So the key points to finish, that the pediatric care is the first step. We need to implement a holistic pediatric care. Of course, they display multi-hormonal dysfunction and metabolic issue that needs to be screened and evaluated and treated correctly. Obesity is about 50% in adolescents, and it's less than 30% younger. Type 2 diabetes may start in the transition period with a mean age of 17. So we need to screen that. Comorbidities are important and may worsen in the transition phase. Psychiatric disorder that need combined medication have to be evaluated correctly. And the most important for us is to leave the patient the choice of his project. And time to prepare it before the transition and discuss it with the family. And we emphasize for many years the need to anticipate curatorship, not to have this decision at the age of 18, but before, and discussing with the patient. And last but not least, discuss the autonomies with the nurse and effective life with relationship, sexuality, and reproduction that I'm sure that it will be discussed in the afternoon. So I want to thank my team, all the collaborators that we have and friends all over the world. And I will finish with the presentation.
Thank you, Maite, for this comprehensive overview, which allows us to have a global approach of this syndrome. We see that it is a multifaceted disorder where the hypothalamus has a central role, and you have presented all the issues and also the foundation of a successful transition that is complex. Perhaps I have to look at the question box if we have questions. I do not see question actually. Perhaps I have one for you, Maite. You mentioned that the hypothalamus has a central role. Would it make sense to target this main region to develop treatments? So can you perhaps discuss with us the treatment we can discuss specifically in the transition phase, because we have a lot of treatments that can target hypothalamus in the different periods in childhood, in adulthood, but could you perhaps discuss on which drugs can be used during this transition, specifically during this period?
You mean for psychiatric issues or endocrine and metabolic?
For hypothalamic, because at hypothalamic level, actually, because you have shown that it's really a main region for all the aspects of the disease. So perhaps hyperphagia, perhaps, yes.
So to answer your question, nowadays there is not approved drug to target hypothalamus in Prader Willi syndrome. What we know is that we have drugs coming now to treat hyperphagia and targeting hypothalamus, for instance, MC4R receptors. And so it is possible that this drug may help, particularly in this period, but we don't know. We have other drugs in trials that are not completely approved by the agency. So right now we don't have approval for that. So, but probably we need to target hypothalamus in the adolescents. You are right. But we need more information. We don't have enough data for that right now.
Okay. Okay, and for you, you mentioned that it's a continuum between childhood and adulthood. How in your experience you can really have this continuum in your staff and in your multi-professional staff and team?
We follow. We don't have a person who are lost for follow-up. We follow them because they want to be followed. They are used to us, so it's easy to continue. But the problem we face is that the families who came from other parts of France, so it's more complicated for them to find teams in all over the country, adult team they want to be followed by. So we have some family, they wanted to come back in Toulouse to be followed, and that's a little bit complicated for us because we face a very high number of patients, and it's very complicated to do everything. So it's but most of the patients have a good transition. I don't know if outside of our center and in Paris with you, Christine, I'm sure that the transition is not completely done, and it's really a challenge for us.
Yes, in our experience, the main issue you mentioned is the transition also for behavioral aspects, and perhaps we can ask Tony to discuss with us this specific aspect. I think it's a transition, another transition, not the transition for care, the transition between speakers. Maite, I let you the floor to introduce Tony.
There are two questions in the inbox.
Oh yes, okay, sorry.
No problem.
I can't see, Sandra, actually, the question.
Okay.
Yes, I don't see neither.
Okay, I will. I have a question from Jean-Paul. I don't understand if you continue GH treatment after 18 years.
We continue growth hormone treatment if the patient wants to continue. We accept to continue, but we perform in all cases a growth hormone stimulation test, just in order to know if they are deficient or not. And we know that less than 50% of adults are growth hormone deficient. But I think that Charlotte Hoiby will follow on that. But our practice is this one. And if the patient wants to stop, because it's half of the patient wants to stop treatment, just to see, as they say. So we stop treatment and we follow them for every 6 months and see if we need to restart growth hormone treatment because of the weight gain, excessive weight gain, and alteration of body composition. And so we discuss with them if they want to resume growth hormone treatment, and in most of the cases they want to. Is it okay?
Okay, I see now the question. We have a question on the initiation of testosterone, but I think we can ask to Laura after her speak. I think it would be better. Okay.
Yes.
Okay.
Yes, we share, because otherwise we will repeat everything. So I decided not to focus on that. Okay. So I now give the floor to Tony Holland. We are very happy, Tony, to have you with us today. Tony Holland is a psychiatrist from Cambridge who spent many years working on and studying on Prader Willi syndrome, and is now the head of the IPSO organization, International Prader Willi Syndrome Organization. And I must say that with him and Dan Driscoll, the IPSO is going very well now, very dynamic. And so we are happy to listen to you regarding this very specific period of transition in this population.
Thank you very much, Mate. It's a real pleasure to be here, and it's great to have attention paid to this psychiatric and psychological aspect. There does seem to be quite an echo. Do other people hear the echo? I think that's better, thank you. So I'm really pleased to do this. And I think your talk, Mate, very nicely sets the scene for my talk. In a sense, what I want to ask is, why do things go wrong in transition? I say this because I think our experience in the UK is, whilst there are times when certainly transition goes well for people with Prader-Willi syndrome, there are unfortunately too many times, I think, when transition goes very poorly. And usually it's because of the psychiatric state and because of behavior. But I think transition is really much more complex than we normally think of it as. It isn't simply moving from education into adult life. There's a whole framework of change that happens at a legal level and at a status. So I'm going to do something that is perhaps a bit unusual, if you like, for primarily a medical audience. I'm going to start my talk by looking at the UN Convention on the Rights of Persons with Disabilities in the context of the European Convention on Human Rights, and ask the question, what does that mean when you move from childhood to adulthood? Then look at the issues around environmental change, and then move to the more biological aspects of Prader-Willi syndrome from a more psychological and psychiatric perspective, and look at the implications of the atypical and delayed brain development that is characteristic of people with Prader-Willi syndrome, and finally touch briefly on physical maturation and growth and how that might impact on services' ability to support people in the transition as they move from childhood to adolescence to adult life. So I don't know how many of you will be familiar with the UN Convention on the Rights of Persons with Disability, but it's really has been seen as a fundamental contribution to recognizing that people with disabilities have the same rights as any of us on this call have as we move to adulthood. And I've underlined one of the phrases here in Article 1 of the UN CRPD, the full and equal enjoyment of all human rights and fundamental freedoms. And in the second paragraph there, you see that the convention defines what they mean by persons with disabilities. Now, I'll come back to some of these issues in a moment, but it's very important for you to see this transition into adulthood in the context of the policy and legal frameworks that in a sense protect us as adults in the respective countries where we live. So the UN CRPD have a whole range of articles and some general principles, and I just want to pick out one or two here. So there's what they call respect for inherent dignity, but autonomy and freedoms, because one of the change that all of you will be aware of is the right of people as adults to make decisions that affect their own lives. And this can have great significance for people with Prader-Willi syndrome. But there's also the principle of non-discrimination, of full and effective participation and inclusion in society. So these are really important issues. But there are other articles, and I want to raise these because in exactly the same way as in the UN Declaration of Human Rights or in the European Convention of Human Rights, it's recognized that there are often tensions between different rights. And at the end of my talk, I'll come back to this, but I want you to notice that it's clearly stated that there's an expectation that the states will commit themselves to providing those services that promote a right to life, that ensures so that the needs, in this case of someone with Prader Willi syndrome, will be met, but also that they have access to justice, liberty and security of person, freedom from torture or cruel and degrading treatment, and freedom from exploitation, violence, or abuse. And what I think we see sometimes is that there are tensions between these different rights. Now, I use that as a starting point because then we can ask ourselves, what is it about this transition to adult life that from a more psychological and perhaps legal perspective is so, at times, so difficult? First of all, people with Prader Willi syndrome will move from a position of parental responsibility and control to one of individual freedoms, choices, and responsibilities. So at 18, that will be a switch. But secondly, that human rights and national, international laws and conventions apply to all, and the non-discrimination and equality of opportunity are overarching principles. So there'll be expectation that people with Prader Willi syndrome, regardless of having disabilities, will have the same rights and freedoms as all of us. And of course, this then creates the challenge that I think probably in all our countries we can see. So in transition and in adult life, how to ensure these rights, but also at the same time, manage risk and protect a person with Prader Willi syndrome from harm. And I think all these things can come to a point at this moment of transition. But I think it's more than that. And I want to now just reflect a little bit on the issues of the changing environment. And I think, Matty, you mentioned how some of these issues are managed in France. In parts of the UK, particularly in England and Wales, we have what's called the CARE Act. And the CARE Act requires that social services undertakes a child's needs-led assessment for children who have a disability and will be have special needs in preparation for a transition. And what essentially, and I've been a bit emotive here, but what essentially they're trying to do is to prevent everything going badly wrong. That's the idea, because everyone's recognized that transition can be so difficult for people with disabilities generally, but particularly for people with Prader Willi syndrome. You know, what's happening in the worst case scenario is people move from the structure of education from school, where they know what they're doing during the day, they have activities and lessons and so on, to the chaos of adult life. So they leave full-time education. And if there's nothing planned or nothing organized, they go from structure to what I've called here chaos. And what that essentially means for people with Prader Willi syndrome is going from certainty to uncertainty. And I think, and I'll come back to this, what is very difficult for people with Prader Willi syndrome is this sense of uncertainty, not knowing what is going to happen. And they can go from a state of activities and structure, as I mentioned, to this sense of sort of emptiness and lack of structure. And this is accompanied by increasing freedoms and choice, potentially access to food. So they may move from a family environment at this point, or at least to having more freedoms in which they can move. They spend time away from the family environment, where cupboards may be locked and access to food may be controlled, to circumstances where access to food is freely available. But I think adult life brings something more than that. It brings having to manage and cope in a new and complex social world, a world in which people are having to, like all of us, are having to make decisions in the context of a changing environment. And part of that, of course, for people with Prader Willi syndrome, there are risks of exploitation and abuse. So before I move on to the more psychiatric aspects, I think that one of the questions that comes up is encapsulated here: who decides? Because adults, like all of us, have the right to make decisions for themselves about things that affect us and our lives. But also as adults, we can be held responsible for these decisions and be accountable if, for example, breaking the law. So one of the questions that countries have to struggle with is for adults with disabilities that affect their intellectual and cognitive development, how do you address these issues, assuming that you require the necessary cognitive and intellectual abilities to make these decisions for yourself as adults? And it's important that for all of us, consent is the key to much of this. So in terms of medical treatment, it's very obvious that if you see a doctor, he or she advises, and you decide whether or not to accept this advice and consent to the treatment. For the doctor to treat you without your consent would be an assault. So consent is really important. And for some people with Prader Willi syndrome, and maybe for many people with Prader Willi syndrome, and I think potentially for this new generation of children with Prader Willi syndrome who've had more opportunities than others, consent will be very important in adult life. And I've put here the need for reasonable adjustments. Reasonable adjustments is a phrase that's used in what's called the Equality Act in England and Wales. And it's what it does is it says to all of us in state and private organizations, when you're supporting someone with a disability, you need to think about how you can help them in ways that will allow them to make the decisions that they need to make about their lives. There's a strong literature on how you can help people with disabilities through supported decision making, a literature that is quite difficult and at times has shown that supported decision making isn't as easy as people might like to make out. But the thinking behind this, of course, is how do you support people to make decisions that they need to make in adult life? In this country, we have the concept of decision-making capacity, and we have the Mental Capacity Act that provides the framework for decision-making where someone may not have the ability to understand what it is they're being asked to consent to. And in other countries, they have what's called either partial or full guardianship. And by and large, that is not seen nowadays as a good thing, because certainly a full guardianship takes over complete control of someone's life. And we've seen how that can go seriously wrong in particular countries in the world. So this, I hope, has given you the, if you like, the more social legal framework and policy framework that really is crucial in how we help people with Prader Willi syndrome and broadly people with disabilities generally negotiate this transition into adult life. Being an adult carries with it very much more freedom and more responsibilities than being a child. And whilst one can grade into that situation, there is, if you like, this interface usually at age 18, which can be very problematic and very challenging. I want to now reflect a little bit on mental health, and Matti, you touched on some of that. But the point I want to make here is that the WHO have argued, and I think very nicely, that mental health is much more than the absence of mental disorder. And really one can draw a very nice analogy here with physical health. If we say someone is physically healthy, we're not just saying they don't have a physical illness. We're saying that they are robust, they can take exercise, they can do the things that they want to. They're not limited by their physical health. And the WHO sees mental health as in that sort of way. And these are some phrases taken from this paper here. Now, if you look at this, like ability to cope with adverse events and function socially, as well as to recognize, express, and modulate emotions, and so on, these are all areas that people with Prader Willi syndrome have serious problems with. And so, we, I think, need to recognize from the start, both as children, but particularly as they transition into adult life, there are going to be serious mental health problems, some of which may fall into the clear categories of a mental disorder, such as a mental illness, but many of them do not. Many of them are about the behavior that arises when someone with increasing independence seeks to interact with a demanding and changing social world. And that dynamic is really very important. Now, at present, the International Prader Willi Syndrome organization has brought people together from all over the world to try and think about how we can best help around the mental health needs of people with Prader Willi Syndrome. And this slide and the next slide are taken from the report that's being prepared about this. But I think it's very obvious, certainly in childhood, if you think about the well-being of a child with Prader Willi Syndrome, it's going to depend on a number of factors, so including the family being able to adapt the environment where the person lives. But also here we talk about dimensions of mental ill health. And what these are some of the factors that are characteristically been shown to be associated with Prader Willi Syndrome. And this takes us back to the atypical brain development, which I'll return to in a moment, and the hypothalamic abnormalities that Matty referred to in her talk. But we know that there are significant cognitive, communication, and social impairments, and I've listed some of them here. There are what we have called behaviors of concern, of which hyperphagia is the best known one, perhaps, but emotional or temper outbursts, what we've called body-focused self-harming or skin picking, repetitive and ritualistic behaviors and rigidity, and so on. But also there are abnormalities of mental state, what we've called mood instability or situational anxiety, affective disorder, and particularly in those with the UPD form of Prader Willi Syndrome, a high risk of psychotic illness. Now, these are all important because some of these will be present from childhood, but may get worse during transition. Others of these may arise for the first time during transition and as the child gets older and becomes an adult. Just for a moment, look at the issues of cognition, and I'm going to come to IQ in a moment. But the point I want to make here is that I don't think IQ is the main issue. I think the main issue around cognition for people with Prader Willi Syndrome is the fact that what are often referred to as higher order cognitive functions are impaired. And many of these, like the ability to recognize emotion in others, the ability to plan and organize, to understand the concept of time, all these sorts of things are often unnoticed and hidden. But they become, as I will argue in a moment, much more important as you move into adult life, where you're moving from the protection of childhood to the chaos of the social world. There's also some evidence that educational attainments are more difficult, such as numerical skills, reading, and so on, may be more difficult for people with Prader Willi Syndrome to retain over time, and that actually repeat practice is really rather important. So they may lose some of these skills if they don't have the opportunity to continue to use them during teenage years and into adult life. I put a slight caveat on this because these studies, many of these studies were done in earlier generations of people with Prader Willi Syndrome, and some of these issues may not be as significantly affected now with the early use of growth hormone, better education, and so on. The other point to make is that, of course, cognitive impairments, there's a distribution. If we look at IQ, the mean IQ in a population of people with Prader Willi Syndrome is generally found to be 40 points below the mean IQ in the general population. But of course, there's a distribution either side of that mean IQ. One of the problems that can arise in it is that in countries who determine the right of access to services, whether it's in childhood or adult life, on the basis of having the criteria for having a learning disability or intellectual disability, what used to be referred to as mental handicap, if that includes an IQ below 70, then there will be people in the population of Prader Willi Syndrome who have IQs above 70. and do not meet criteria for having a learning disability, and this can be problematic for them. But the point that this slide really tries to illustrate is that, of course, you can't assume that someone with Prader-Willi syndrome will have a low IQ. There's almost certainly that their intellectual and cognitive abilities will be impaired compared to that of their family, but not necessarily compared to everyone in the general population. Now, these observations become important because in childhood, what's often referred to as the disability gap, so the gap between a person with a disability and the general typically developing population, may not be too great. But in adulthood, this gap becomes bigger because these higher order skills are not acquired. And it's these higher order skills that become so critically important, and in their absence may help to contribute to some of the psychological and behavioral difficulties that we see in adult life. The other point to make is that there are now, and this is a rather taken from a review that Kate Manning and I did some years ago now, and there have been new studies since then. But I think there have been really a number of brain scanning studies that have shown the extent of brain abnormality, of impaired development of the brain in people with Prader-Willi syndrome that involves both subcortical and higher order structures, as well as, of course, the hypothalamus and its connections. So I think it's reasonable to argue that there is quite significant abnormality of brain development and associated high order cognitive dysfunctions that's going to impair and make transition particularly problematic. And this is another taken again from the international working group that we're engaged in at present. And there's some really interesting neuroscience theories about how the brain maintains a model, an internal model of the external world. And I think one way of thinking about people with Prader-Willi syndrome is that they have an impaired understanding or impaired perception of their internal state, such as hunger, but they also don't have the full experience or understanding of the external world because of their inability, for example, to recognize emotions. So they are making decisions on the basis of impaired knowledge of how the world is and is functioning. So the impact of cognitive impairments on learning and education attainments and their maintenance over time may be a problem. Their ability to reliably interpret and make sense of the physical and social environment may be impaired, and therefore their ability to respond to and make decisions in an efficient and effective way and to respond to change may be problematic. So I now just want to focus down finally on the specific aspects of mental health. If you look in the typically developing population, the risk of psychiatric illness such as mood disorders, anxiety, psychotic illness rises during the teenage years. If you look at some data here from Lauren Rice in Australia, emotional outbursts characteristic of Prader-Willi syndrome, she reported increased in the teens. And of course, you've got the increasing physical size, particularly now that people are on growth hormone, of the person with Prader-Willi syndrome, which makes emotional outbursts much more difficult to manage. So in transition and in adult life, it's more likely that, for example, we might get involvement of the police and the criminal justice system, certainly get further family stress, and we may have placement breakdown, if you like, simply because of this combination of problem behavior and the physical size of the person. This is data from studies that we did some years ago looking at rates of psychotic illness in people with deletion and UPD. And you see here that we found that about 60% of people with UPD in adult life, and this was a population of adults, had either a history of having had a psychotic episode or were at the time had a psychotic illness, compared to just under 20% of those with a deletion. And Lucy Aman, who's doing a PhD with us, has just completed a systematic review of psychosis in Prader-Willi syndrome. This is focused on the clinical aspects, and the studies, 14 cohort studies and 25 case reports, including 937 participants, here, she found that the usual age of presentation of psychosis was in the teens to early adulthood, as shown here. So the darker ages are where most people presented with psychosis. But the earliest reported age in this study, in this review, was 8 years of age. And then there was someone who had no episode of psychosis and developed one for the first time in their 40s. So there's a very big range. But the point about it is that someone with Prader Willi syndrome may develop problems in transition. Their behavior may deteriorate, and people put it down to the transition, when of course it may be that they have developed a psychotic illness. So what are the implications of the change in environments, in the neuropsychology and cognition, and in the mental health aspects? I strongly believe that this right-based approach to preparing for adult life, making the case for the right support and services using evidence, is really important. Part of that, of course, there are competing rights. So giving someone choice may bring it risks of overeating and obesity and early death. There are those tensions. And a paper by Elizabeth Fistine on behalf of the International Prader Willi Syndrome Organization has looked at what the courts say about these issues. Of course, we have to prepare for change, and one needs to think about how you do that in a way that helps to mitigate the problems that come with the cognitive impairment, such as by using visual material. Be aware of the possibility of developing psychiatric comorbidities and have strategies in place to manage them. I don't know about in France and other countries, but in the UK, we can sometimes have a nightmare if someone with Prader Willi syndrome suddenly becomes mentally unwell. The services struggled to provide for their needs. We clearly need, as is expected under UNCRPD, to allow people to take risks, but we need to have the means to respond if that goes seriously wrong. So if I was asked what are the 3 key components, it is engaging with the person with Prader Willi syndrome from childhood so they understand the issues and will ultimately agree to and consent with a transition plan that addresses these issues. But of course, none of this is any good unless in your country you have the opportunities that people with Prader Willi syndrome can take, such as education and employment. And of course, you need the funding and you need the health and social care support services, including the involvement of the national Prader Willi associations and so on, to address these needs and to follow up people over time. So this is a rather rushed psychological perspective on transition. And thank you very much for your attention. Very happy to take any questions.
Thank you very much, Tony, for this wonderful overview and very new for many of our aspects. I have to look at the question. I don't
look at
see
the question box
you.
to see if we have them.
Yes, I don't see question at the moment. I
have a question for you, Tony. I have one for you, Tony.
Yeah.
Do you hear me?
Yeah. I can't
Do you
hear
hear me, Tony? Yes. Yeah. You mentioned that transition is associated. Okay. Can you hear me? Yes.
I can. There's quite
you
an
mentioned that the transition is associated with. Oh, sorry. How I can perhaps without my webcam, it's better. Do you hear me, Tony?
Yes, I do. Yes.
Can you hear me?
Yeah.
Yeah, it's better. So you mentioned that the transition is associated with the worsening of psychological equilibrium and also occurrence of sometimes psychosis symptoms. Do we have predictive symptoms early for teenager, for example, to predict or to try to predict the occurrence of psychosis development or
Right. It would be very nice if we did, but I think the answer is we don't at present. there has been one American study that tried to do that and didn't identify any precursors. We are doing that at present. We're trying to look at that. I think one of the difficulties is that the majority of cases of psychotic illness start very abruptly. I mean, sometimes within hours, the change can be very quick. There are others that are slower than that. But at present, all we know is that the people with dysomia have a greater risk, but we don't have any clues to how we can then predict exactly who will go on or who might be developing a psychotic illness. I wish we did.
Thank you. Yeah, it will be useful actually to have, to anticipate the crisis. And
I think one of the interesting things, by the way, is that some people are put on psychiatric medication for their behavior, perhaps in childhood or in adolescence. Whether that's right or not is another matter. But that actually might suppress the development of psychosis in later life. So there may be some people who would have developed psychosis, but actually are prevented from doing so by the fact that they were put on medication for other reasons. But there's a lot that we still need to disentangle through research.
Okay, thank you, Tony. No other question in the box?
Yes, there are questions. There are questions, Christine. There are questions in the question box. It is. I think that this one is interesting. I'm sorry. Do you have any example of an adult with PWS with normal IQ that can manage life without any services? From Erica Almen. Can you answer, Tony?
Tony, please unmute yourself.
Did you hear the question, Tony? Or?
Thank you. Someone's unmuted me. Yes, I heard the question. Whether I do, we have one person I know quite well in this country who went to university, and I think life, however, has not been easy for her. She has largely managed her own eating behavior, although she is someone who is overweight, but perhaps not overweight when you look at the spectrum of BMI in the general population. But the trouble is that she's been unable to find any form of employment. She had very significant problems in terms of social relationships at university and then afterwards. So I think our sense is, by and large, that the vast majority, if not all people with Prader Willi syndrome, need some level of support, and almost all of them will need some support around the issue of eating and around the issues of social functioning and engagement in employment and so on.
Just to make the transition, listening to your talk, Tony, I have a dream that probably when transition starts and during adulthood, the coordinator of care for a person with Prader Willi syndrome may be a psychiatrist, because the way we are doing now is to put endocrinologists or nutritionists, to put on the scene the arthrophagia and endocrine disorder, but probably it is the opposite that we should try to push. Of course, it's a lot of work to do, but I think it would be a different view of what we are doing these days. What do you think about that?
Yeah, I mean, I think the management of transition, one of the questions is where does the responsibility lie, if you like, for that? And I think we in health, of course, are increasingly specialized. And I think it's actually one of the challenges for us when caring for someone with Prader Willi syndrome is how one addresses that issue of specialism. In this country, it would be social services that would be responsible for preparing for and managing transition. And of course, they may or may not be knowledgeable about Prader-Willi syndrome. And I think one of the great challenges we have is how do we make certain that those that have the responsibility for overseeing the process of transition really understand Prader-Willi syndrome? Because what they do is that they, and in a way this is a positive thing, that they will say to people with Prader-Willi syndrome, as an adult you have choices, but they won't counter that with the risks and the issues around eating and so on. And this is where I think the problems can arise, is if you have a social worker or someone who lacks knowledge about Prader-Willi syndrome and sets up expectations for people with Prader-Willi syndrome that are clearly not going to be fulfilled or not going to be possible.
Thank you, Tony,
Okay,
for
thank
this
you
wonderful.
very much, Tony, for your speak and the discussion. We now move on to the endocrine care of the young adults, and it's really a great pleasure to welcome Laura. Hello, Laura. Laura currently works at the Department of Internal Medicine Endocrinology at Rotterdam, where she focuses on patient care and research involving rare genetic syndromes, and especially Prader Willi syndrome. So happy to hear you today, Laura, on adrenal insufficiency and hypogonadism in Prader Willi syndrome. The floor is yours.
Please unmute yourself.
Yes, and it said I cannot unmute myself, but now I can. So that's nice. Thank you, Christine, and thank you for the invitation. Well, so I will show you our data on adrenal insufficiency and hypogonadism in adults with PWS, and I will be talking on behalf of the multidisciplinary team of the Center for Rare Genetic Syndromes, which also includes psychologists and psychiatrists. So next slide, please. These are my disclosures. Next slide. And all the data that I will be sharing, well, there I have to give a big thank you to the Informed PWS network, which is an international network of adult endocrinologists from Europe and Australia. We have a very close collaboration with regard to all kinds of endocrine problems in adults with PWS, and I'm really grateful for that. Next slide. So, as you know, PWS is associated with all kinds of endocrine deficiencies like hypothyroidism, hypogonadism. But with regard to central adrenal insufficiency, there has been a lot of discussion lately, because in children and in adults, several reports from the literature have given different prevalences of central adrenal insufficiency, from now on abbreviated as GAI. And we really wanted to know what is the actual prevalence of this important disorder in adults, especially because symptoms of GAI are less reliable in PWS. For example, normal symptoms of GAI in the non-PWS population include fatigue, muscle weakness, and weight loss. But in PWS, there's a lot of daytime sleepiness. So fatigue is not really a reliable feature. The same is true for muscle weakness, because we know PWS is associated with hypotonia. So muscle weakness is not really a reliable symptom. Weight loss is not reliable because many adults with PWS are on a diet. And so weight loss can happen also when there's not GAI. Next slide, please. Can I have them? Yeah, thanks. So this is an overview of all the data of all the groups that have studied CAI in children and adults with PWS. Some studies have found no CAI in pediatric and adults with PWS. Some have found lower prevalences. And as we know, that the Dutch pediatric group has found a high prevalence of 60%. Next slide, please. So when we are talking about transition, it's important to know that the Dutch guideline, which is largely based on the Dutch pediatric study, prescribes stress doses of hydrocortisone during physical or psychological stress in all patients with PWS. And as we see in the adult population, a lot of problems like weight gain, osteoporosis, diabetes mellitus, and hypertension, we were really concerned about this high hydrocortisone use because we know that the side effect of frequent hydrocortisone use are typically these features: weight gain, osteoporosis, diabetes, and hypertension. So we want to prevent overtreatment, and therefore it's very important to know the real prevalence of CAI in adults with PWS. Next slide, please. So together with the Informed PWS network, we did a retrospective study in 82 patients with PWS, and we collected data on metopiron tests and insulin tolerance tests. We included 46 males and 36 females with a median age of 25 years and a median BMI of 29, and 28% of them were on growth hormone treatment. And the cutoff values for CAI for the metopiron test was below 230 nanomolars per liter of 11-deoxycortisol. And for the insulin tolerance test, the peak cortisol should be below 500 nanomoles per liter, except for the patients from the UK who had a lower cutoff value of 450 nanomoles per liter. Next slide, please. So here you can see the results of all the metopiron tests. On the y-axis is the 11-deoxycortisol level. And on the x-axis, you can see the baseline cortisol, which is always taken the morning before the metopiron test. So that's the morning cortisol. The red line indicates the cutoff value for CAI. And as you can see, all the dots are above the red line. So none of these patients had CAI. Next slide, please. These are the results of the insulin tolerance test. There was one patient who was slightly below the cutoff value of 500 nanomolars per liter. He was on 494 nanomoles per liter, so he was diagnosed with CAI, which brings the total prevalence of CAI in these 82 adults to 1.2%. Next slide, please. So we were really surprised because this is a large difference from the pediatric findings. So we wanted to know what happens in clinical practice. We studied the medical files of 645 adults with PWS to see whether they had undergone surgery without hydrocortisone, because that would be the ultimate proof of the fact that their adrenal response would be normal. If you undergo surgery without hydrocortisone infusion, then of course, and if you don't have any clinical problems, then one can conclude that you don't have central adrenal insufficiency. So we studied all those medical files and found that 200 patients underwent surgery without hydrocortisone stress dose. And of those 200 patients, none of them had features of clinical findings corresponding to hypocortisolism. And those 200 underwent surgery without hydrocortisone stress dose because that was before the guidelines existed, or because they were operated in a country where the guideline did not prescribe routine hydrocortisone treatment during surgery. Next slide, please. So concluding, CAI is very rare in adults with PWS. This is in contrast to the children population. And to prevent overtreatment in adults, we advise against routine hydrocortisone administration during physical or mental stress. If there are clinical symptoms, so really a clinical suspicion like fainting or hypotension during stress, of course, then it's necessary to perform dynamic function testing like middle iron test or ITT, and only administer hydrocortisone stress dose if CHI is confirmed by one of those tests. Those are the major or the most important findings from this study, and I will now proceed to the hypogonadism. Next slide, please. Oh, I'm sorry, I forgot one thing. Of course, there has been a lot of discussion about the difference with the pediatric data, and I think we have a lot of we have been searching for explanations why these findings are so different. I think that's beyond the scope of this presentation, but I want to share all the arguments and the discussions with you of the possible explanations. Through these QR codes, you can access the free full text of the JCNM article where you can see all the, let's say, the argumentation about it. Next slide, please. So I will now focus on hypogonadism. These data of Carlijn Pelikaan, she was the first author, has just been published. So this QR code brings you to the free full text of that one. Next slide, please. I will first focus on the males with PWS. We studied 57 males with an age group of a median age of 29 and a median BMI of 27. The genetic subtypes were as expected in the PWS population, and I think for this specific topic it's important to look at the relationship status. 4% were in a relationship with sexual intercourse, which is of course important if we are talking about hypogonadism. We also looked at cryptorchidism, and I have a very small screen here, so I have to look at my own slides. 94% had cryptorchidism. No, I must say 63% has cryptorchidism, and 94 of them underwent surgery for that. So I think we have now a kind of an overview of the population that we studied. Next slide, please. Yes, it's important to know that some patients were already diagnosed with hypogonadism before their first visit to our clinic. So 49% of the 57 patients that we studied already had a diagnosis of hypogonadism, and 86% of them were treated, which means that 14% had untreated hypogonadism. So the referring physician knew that they were having hypogonadism, but they were not treated. And the main reason for not treating was because the physician himself or the parents or caregivers were afraid of behavioral issues after starting testosterone treatment. I'll come back to that later. Then during our screening, we newly diagnosed 28 patients, another 49% of our population. And that brings the total to 98% of all males having hypogonadism, which is just, well, close to 100%. So everybody, almost everybody had hypogonadism. And the ones who were treated were mostly treated by testosterone gel. Next slide, please. As I said, there were some reasons for not starting testosterone treatment or for giving a lower dose than usual. In the lowest pie, you can see the reasons for not starting, and in the upper, the reasons for not increasing the dose, because there were a lot of patients who did use testosterone gel, but at a very low dose, and they were not having normal levels of testosterone in their blood. And the main problem, as I just said, it was the fear of behavioral challenges after starting testosterone treatment. Next slide, please. Well, we were also interested in the type of hypogonadism, because as Maite showed in the first talk, of course, PWS is mainly a hypothalamic problem. So one would expect that hypogonadism is a central form, a hypothalamic form of hypogonadism. But as we saw, there were also a lot of patients who had low testosterone levels, but with increased levels of LH and FSH, which indicates a testicular origin of hypogonadism. And that was the case in 21%. Next slide, please. There are also a lot of people who say, well, people with PWS, they have hypogonadism because they have obesity. And that's a logical way of thinking, because when you are obese, you have a lot of adipose tissue, and adipose tissue converts testosterone to estrogen. So it would be logical to think that that obesity would be the cause of hypogonadism. But that's not the case in many patients. We saw that also in people with a normal BMI, with normal weight, they also had hypogonadism. Next slide, please. So the conclusion for the male part of hypogonadism is that hypogonadism is present in nearly all males of males with PWS, 98%. It can be hypothalamic or testicular in origin, or a combination of both. Many patients had treatment that did not lead to normal serum testosterone levels. Only 1/3 of the patients received adequate treatment, and a major problem in the West was the fear of behavioral challenges or actual observation of behavioral challenges after increasing the dose. Now we know from experience that if you start treatment at a low dose, like half or a third of the dose you would give to a normal, let's say non-PWS male, if you start at half the dose and increase really slowly, then these behavioral challenges often do not occur. So we believe that it's important to prevent undertreatment, and that's why we made a practical algorithm for physicians that they can follow in order to reach normal serum hormone levels of testosterone. Next slide, please. Of course, this algorithm is quite detailed, so I won't take you by the hand and read all of it, but you can look at this figure by using this QR code. And the main, the most important part of it is that you start at very low dose and slowly increase the dose. Just take the time over months or even a year. The most important thing is not to get behavioral challenges, because once a patient gets behavioral problems or challenges, then the parents and the caregivers and the patients themselves will never want to go back to that treatment, because it has very large impact on their life. So it's very important to prevent those behavioral changes from happening. And it's also very important to explain to the patients what they will notice after starting therapy. They have to get explanation about that they will get erections, that they will have sexual interest, so that they won't be afraid once that happens, and they won't get confused by that. So those are the main 2 points of this algorithm, but you can have a look at it by the QR code. Next slide, please. Then I will focus on female hypogonadism. Next slide. We looked at another 64 patients, so 64 females this time. Median age was 28. Median BMI was 32. Like in the males, the genetic subtypes were as expected. And here, the use of psychotropic medication is important, because estrogen can have an impact on the psychotropic medication, and that was present in 38%. And as in males, just a small minority of the population was in a relationship with sexual intercourse. One of our patients is married, and she was one of those 9% having a relation with sexual intercourse, which is important when we are addressing this topic of female hypogonadism. Next slide, please. So, as in males, some women were already diagnosed with hypogonadism before they came to our center, 60%, and 23% of them were not treated. And there, the most important reasons for not treating were the fear of behavioral issues, like in males, but also the fear of having menstrual bleedings. So many times the caregivers or the parents were afraid of how the patient would respond to seeing blood, and they were also having concerns about hygiene, the menstrual hygiene, because especially in patients with intellectual disabilities, this can be a challenge. Then our screening revealed another 17 women with hypogonadism, and that brings the total to 94%. So like in males, almost all women had hypogonadism, and 28 of them were untreated. As in males, it was not only due to obesity, because in the females with a normal weight, so the females with a BMI below 25, also 100% had hypogonadism. Next slide, please. So as in males, we looked what the origin was of hypogonadism. Also here we thought it would be primarily hypothalamic of origin, but also here we saw that some patients had high LH and high FSH, so that indicates that there's a primary ovarian cause for the hypogonadism. Next slide, please. So in conclusion, 94% of all PWS women had hypogonadism. We all know that it's important for bone health and also for general well-being to treat hypogonadism, but it was often left untreated. The main reason for not treating was, on one hand, the fact that estrogens can have interaction with psychotropic drugs. So there was a fear of behavioral changes. And on the other hand, there was a fear of having problems with menstrual hygiene. So also for the females, we developed an algorithm to help the physicians treat their patients and to prevent undertreatment. Next slide, please. And this algorithm, well, the same for the sake of time, I will not guide you through it, but the most important issues are informing the patient that especially in the beginning, some menstrual bleeding may occur. They should know that blood is not dangerous, that it's normal, and that they should be explained how to handle the menstrual bleeding. If the menstrual bleeding is a problem, or when the caregivers and the parents think that it will be a problem, then one can always choose a hormone, like a preparation that's not causing menstrual bleedings, like tibolone or femostone continuous replacement therapy. They cause some menstrual bleeding in the beginning, but after a few months, these bleedings will stop and there will be no menstrual bleeding anymore. So that can be a way to prevent well, both the fear and the hygiene problems in females with PWS. And I believe that it's really important to try and prevent all those problems from happening, because undertreatment is the most is the largest problem in this population. So if we manage to have all the women with hypogonadism treated, and then I think we can win a lot, both with regard to bone health, but also with general well-being. Next slide, please. So the overall conclusion, both for central adrenal insufficiency and hypogonadism, CAI is really rare in adults with PWS, and I believe that in order to prevent overtreatment, it's important to advise against routine hydrocortisone stress dose in adults. We have to perform a dynamic testing in every case of clinical suspicion of hypocortisolism, but then only administer routine stress doses if CAI is really confirmed by ITT or made-up iron tests. And for hypogonadism, it's present in nearly all patients, both females and males with PWS. Undertreatment is the largest problem, mostly because the fear of behavioral challenges and hygiene problems. And to prevent undertreatment, please follow the practical algorithms. That was what I wanted to tell you. I suppose there are some questions. I want to thank all the collaborators of the Center for Adults with Rare Genetic Syndromes, including the multidisciplinary team, and would like to thank you for your attention.
Thank you, Laura, for this really comprehensive overview and really practical. I think it's really useful that you showed the practical algorithm and useful for all our colleagues in endocrinology. So I look at the question box. Do we have questions? Yes, before we have a question. During the talk of Maite, do parents report the adolescents with Prader Willi syndrome have more aggressive behavior after initiation of testosterone? If yes, what are the options we have?
That's a very good question. If the testosterone treatment is started in a normal way, I'm sorry, I hear echo. Could you please mute? Yeah, thank you. So if testosterone is started in a normal dose, let's say the dose that we give to non-PWS adolescents and adults, then you will have a very high chance of having behavioral challenges, including aggression. So we never do that. So it's very important to start at a low dose, like for example, using the gel, just 10 milligrams of gel, really the lowest dose. And if we are talking about testosterone injections, so the short acting, start with 250 milligrams once per 3 weeks or once per month. So really half of what you would do in a non-PWS male. And then wait very long before you go to the next dose. This is both to give the parents and the caregivers and the patient themselves the confidence that nothing bad will happen after starting the testosterone, but also to make sure that the body gets used to seeing testosterone, because they have been hypogonadistic for all their lives. So if you start testosterone in a higher dose, the body and the brain will be shocked, literally. So really increase at a very low pace.
Okay, thank you, Laura. Another question is the risk of venous thrombosis increased by estradiol in Prader Willi syndrome women?
Yes, it is. And I think, therefore, it's important to choose a type of hormone replacement therapy with the lowest estrogen. So we all know that the hormone replacement therapy that we usually use for postmenopausal non-PWS adults has a much lower estrogen content than the oral contraceptives. So what we do in the Netherlands, I'm now speaking for the Netherlands, we will only start the high dose when somebody is sexually active and needs oral contraception. If somebody is not sexually active, we use the lowest dose, which does not have the contraceptive effect, but it does have the good effect on bone health.
Okay, thank you, Laura. The last question, what do you mean exactly when you say normal level of testosterone? For example, if we evaluate normal boy who is 4th Tanner stage, we have the reference ranges established, but the reference ranges for men are, for example, from 5 to 27. So where is the normal? Around 20, for example?
When I talked about the normal range, I was referring to the non-adolescent adult range, and that is testosterone above 11 nanomoles. I'm not sure whether nanomoles or picomolars per liter, so above 10 and 11. For the adolescents, well, I should say Anita Håkon is the expert for the adolescents in the Netherlands, because we are not treating the adolescents. That's really for the pediatricians. So the normal ranges that I was referring to are really the older adult ranges.
Okay. I don't see other question. So thank you, Laura. Thank you
welcome.
very much.
It was a pleasure.
Okay. So now, Maite, do you want to introduce
Yes.
Charlotte?
Yes.
Yes.
I will introduce Charlotte Ogbay, who is a good friend and a very good endocrinologist, adult endocrinologist, with a long-term experience in managing adults with Prader Willi syndrome from Stockholm in Sweden. So, Charlotte, you can start your presentation, and thank you to be there with us.
Thank you very much, Maite, for the kind introduction and for inviting me to this webinar. And next slide, please. Here are my disclosures. And next slide. Transition of care from pediatric to adult care is functioning different in pediatric service compared to adult service. As we have already heard a couple of times now this afternoon, pediatric services are usually functioning very well and with a well-established multidisciplinary team. In contrast, adult services are less developed, and the number of adult Prader Willi syndrome clinics are insufficient, and in many cases there is no team. And this, of course, also affects the part growth hormone treatment takes in transition of care. Next. There are some challenges and questions in transition of care when considering growth hormone treatment. And firstly, Prader Willi syndrome is a complex disease and with multiple comorbidities, and therefore there is a multitude of confounding factors affecting growth hormone secretion. Patients with Prader Willi syndrome are vulnerable patients, and they have cognitive and behavioral disabilities, and also obesity and other hormone deficiencies, which are both often present, can affect growth hormone secretion. And the questions are, do patients with Prader Willi syndrome in the transition phase have growth hormone deficiency? And should growth hormone treatment be continued after adult height has been reached? And what are the treatment outcomes? And next slide. This is just to remind you of the effects of growth hormone in the body. So it increases skeletal growth and has it improves body composition by increasing muscle mass and decreasing fat mass. It has beneficial effects. Oh, I forgot. It increases metabolism and has beneficial effects on blood lipids. And it also increases blood glucose and improves quality of life. And in the figure, you can see the secretion of growth hormone in relation to age. And the top is, of course, puberty. And after puberty, the growth hormone secretion decreases, but it never becomes zero. And next. Currently, Prader Willi syndrome is an approved indication for growth hormone treatment in children with Prader Willi syndrome in many countries. But in the transition period and for adults, it's only approved in a few countries. And therefore, in most countries, the diagnosis of adult growth hormone deficiency must be established according to guidelines. And next. So does the growth hormone deficiency persist beyond childhood in Prader Willi syndrome? The growth hormone stimulation tests that are performed in adults have shown a growth hormone deficiency frequency between 0 and 67%, but most of the tests that we use to measure growth hormone secretion stimulate the pituitary gland, and therefore it might be a falsely normal growth hormone secretion because Prader Willi syndrome is a hypothalamic disease. IGF-1 levels are below normal in 75 to 91%, but we know that there is a large overlap between growth hormone deficiency and healthy controls, and IGF-1 is also affected by nutritional status and hypogonadism. There might also be some differences in growth hormone molecular weight, or defects in the growth hormone receptor, or maybe insufficient spontaneous growth hormone secretion. And these are things or situations that are not fully elucidated yet. And Prader Willi syndrome is a multi-system disease and requires different interpretation of the testing and examinations compared to a typical growth hormone deficient patient. And finally, we know from all studies of growth hormone treatment that growth hormone has significant benefits on growth, body composition, physical and psychosocial function in both children and adults with Prader Willi syndrome. And next. In children, there are many studies which have all shown that height, body composition, motor skills, cognitive function and behavior improves during growth hormone treatment. And here are two girls, and one of them is treated with growth hormone, and I think the difference is very clear. And next. There are only a few studies on growth hormone treatment in the transition period, and this is one of them, and it is a crossover study in 27 young adults with Prader Willi syndrome, where growth hormone treatment was discontinued after they had reached final height. And as you can see in the upper part of the figure is body fat, and if the dotted line is during placebo treatment, and you can see that body fat increased during placebo treatment, and in the group that got growth hormone, it decreased. And in the lower part of the figure is lean body mass, and it goes in the opposite direction, so it increases during growth hormone treatment. And next slide. This is from the same group, and in this study they looked at cognitive functioning, and they could not see an impairment during placebo treatment, but they did see a greater loss in IQ points in patients who had lower cognitive functioning during the time they got placebo. And next slide. So this is from our Scandinavian study, which was a growth hormone treatment study of adults with Prader Willi syndrome. And you see here a CT of the abdomen and of the thigh. And at baseline and after 1 year of growth hormone treatment, and you see here a decrease in fat in the abdomen from 81.4 millimeters to 56.5 millimeters, and in the thigh from 54.2 to 39.9 millimeter. And next slide. This is from some of my adults with Prader Willi syndrome who have had growth hormone treatment for a meantime of 20 years. And what I wanted to show you here is that the body composition as measured with bioimpedance is normal in these patients. So in the men, there's a clear the amount of lean body mass or free fat mass, as it is called when its bioimpedance is larger than the fat mass. In women, there are more fat, but this is expected. It is also so in other people without Prader Willi syndrome. And next slide. This is from a recently published meta-analysis of 12 months of growth hormone treatment. It is from Laura's group in Rotterdam. And the meta-analysis showed, as you can see in the forest plot, that all studies showed that lean body mass increased during growth hormone treatment, and in the lower part it's fat mass, and it decreased. And the increase in lean body mass was 1.95, and the decrease in body fat was minus 2.23%. And this is comparable to what we see in other patients with growth hormone deficiency. And next slide. There are also some studies, a few, looking at physical fitness during growth hormone treatment, and they all reported improvement. And next slide. In the studies that looked at bone mineral density, an effect of growth hormone could not be seen. But maybe the studies were too short, and there are only a few. The next slide. In the studies looking at neuropsychological tests and quality of life, an improvement was also reported in all studies. And next. A few unexpected side effects were seen. There were no compliance or adherence problems reported. There were no major safety concerns in the studies that were performed during transition. There was a small increase in fasting glucose and trends towards a higher insulin and insulin resistance, but not for diabetes. And this is expected as growth hormone increases glucose. And there was also a few transient and dose-dependent side effects. These were joint pain, headache, nausea, and edema. And next slide. There has been some concern in children with Prader Willi syndrome that growth hormone treatment might affect respiration. And this is what you see here is data from the Scandinavian growth hormone trial, and we did not see any differences between placebo and growth hormone treatment on polysomnographic data. And the patients continued with growth hormone for between 2 and 3 years, and no differences were seen either in the longer term. And next slide. So my conclusions are that Prader Willi syndrome is a hypothalamic disease, and growth hormone deficiency is permanent by nature. Growth hormone treatment has many beneficial effects and few side effects in Prader Willi syndrome, and should be offered to be continued during the transition phase and in adulthood. It is important to remember that growth hormone treatment is not a weight-reducing treatment, but it relieves some of the adverse effects of Prader Willi in adults. But however, it is only approved in the transition phase and in adults in a few countries. Growth hormone treatment is expensive, and maybe a lack of reimbursement may be a negative factor for continued use in many countries. And I think that efforts are needed to increase the perception of the benefits of growth hormone treatment in Prader Willi syndrome, in advocating for continued use in adulthood and during transition phase. Yeah, and then I think I have this last slide. I can't see it, but thank you. It only says
Thank you, Charlotte. The last slide was a thank you.
Yeah.
Now it's the time for some questions. I didn't see any questions in the box. So
at the beginning, during Tony's talk, we have this question. Recent studies showed initiation of growth hormone therapy before 2 years old did increase the IQ level from mean 60 to 70. How does this affect the overall cognitive function at the latter part of their life?
It's difficult to answer. I think they are all individuals with different capabilities, but I know that studies have shown that they get a better cognitive function, and I think if I look back in time, I think the cognitive function has improved over time. So as I see it, just by thinking about my patients, I think it's true.
Okay, we have two questions on growth hormone treatment and sleep apnea. Do you use when there is also sleep apnea? Two questions on that, on this association of growth hormone treatment and sleep apnea.
And is it just if we use growth hormone if the patient has sleep apnea? Yes,
yeah.
We do that. But if it's very pronounced sleep apnea, of course they need to be treated for that as well.
Okay. Okay.
But I think also it's not the same as in children, because the doses of growth hormone that we use in adults are much smaller, and the effect on respiration would be expected to be low or not present, as we saw. Yeah.
And could you please, Charlotte, elaborate on the doses of you use, because you say that it's not the same in children, adolescents, and in adults. What is your strategy to decrease the dose during transition?
My strategy is they come to me when they are 18 and we have normal levels for IGF-1 at that age. And my strategy is to keep them within the normal level of IGF-1 for their age, if possible in the upper part of the normal level. But when they come to me, the women would typically have maybe 1.2 milligram of growth hormone per day, and the men something like 0.8, 0.6, and then within maybe 2 years it is time to decrease the dose. They are very sensitive, and the older patients I have with Prader Willi syndrome that are on growth hormone treatment, they have many of them 0.2 milligrams, so it's very low dose.
In adulthood, the mean dose.
When they are 40, 45, 50,
Okay, thank you very much. Maite, I do not have any other question in the box and from my side. Is it okay for you?
There is one from Jean-Paul Thyssen about he didn't understand if we continue GH treatment after 18 years. So in France we do that if patients in our team. So if patients want to continue, we continue, and if not, of course, and if he has a test below 6 nanogram per liter, so per milliliter, we wait. So I didn't see the question, so
No, we do
meeting.
not have any question. And now we are a bit late, so perhaps we have to stop. Thank you, Charlotte.
Thank you.
We will. Thank you very much. So we will meet again normally at 4. So we have now a short break. I propose to you to have a short break for 5 minutes and meet again at 4. Is it okay for you, Maite?
Yes, it's a pity because the film is more than 5 minutes, but
Yeah.
okay.
Oh, normally we have we could watch the movie during the break, but perhaps Sandra could send us the link and launch for 5 minutes the start of the movie, and after we can watch after the symposium.
Yes,
Okay.
that can be arranged. Yes, no problem. But I will start the movie right now, and then we will come back at around 4 o'clock. We start with your presentation.
Yeah, in 5 minutes actually. Yeah.
Yes.
Okay. See you in 5 minutes. Okay. Bye bye.
Hello, my name is Agnes. I am 26 years old. I live on a little farm in the mountains near Salzburg. Today I want to show you a little bit from my life.
Geht noch was?
And now let's go to work.
I was 85 kgs. After that, I left my Akshar school and joined my weekend school. I go there. I made more friends. After that, I went to the dietitians to get proper nutrition and good healthy diet. And after doing that, I did exercise with my my personal trainer who comes in our building and do exercise with me. Then he leaves. After that, I lost some kgs.
So he had developed a sleep apnea as well, and he just did not like to put the mask on and sleep every night. So he got very motivated about losing weight, and he came down in about 6 months. He went down from 85 kgs to 62. You reached 62, right? In between, he reached 62. I always tell the parents that it is very important to do their annual medical tests, as well as keeping the child fit as much as possible, keeping their physical activities, and we keep pushing it every now and then. We keep talking about our child's we motivate them by showing them videos of what our children are achieving and doing, so that the other parents in the group are motivated to do the same. But unfortunately, the children who we've lost over the years from the Indian Prader Willi group has been the parents who've not kept in touch with us, who've not communicated with us. So I feel that the parent-to-parent mentoring, the whole program, and the being connected to the group is so important that they should not shy away from doing that, and just gain from what each other we all can, we offer.
Laura, can you tell me some of the things you enjoy doing in your life?
Horse riding and swimming.
Laura, can I ask you about your school days?
Yeah, I enjoyed school. It was stressful, but it was nice. I learned a lot. I learned a lot in school, but I learned a lot. It was enjoyable. And yeah, I don't know what, yeah, I learned a lot, but it was hard. You know, I need my own SNA, but I also find it was, I don't know about the teachers, but when you need Prader Willi, you need the teacher. I know you have your SNA, but the teacher needs to sit down with you a good amount, even with the SNA that not there and there, because to help you do the work and understand it properly what you're doing. And a lot of the time when you're working with your teacher and your SNA or both, you learn a lot more. It's absolutely essential that you don't have strict staff, but you need to have staff that are fun because fun and has good ideas, and you need to have people that are good at knowing what, you know, like good activities to do, or I don't know, like, I don't know, just lots of different things. Like,
Have you any hopes or dreams for the future?
Yeah, I hope that I have the confidence, and I hope that I want to get a job. I want to get a job. I'm seriously considering going to college to learn something complicated, or something, I don't know, go to college and get a degree in something, or I want to have my own I'd like to have my own family. I have a boyfriend. I want to have the option of getting married. You know, I want to be able to do everything as other people do.
Okay, thank you. It was important to see the movie in full, actually, because testimony which is really touching and instructive, testimony from patients. So now we will start for the second part of this afternoon, and we will address the issue of care pathway coordination in Prader Willi syndrome. I would like to introduce the interview of Sandrine Botius, who is with me today, who works with me for the coordination of transition. So,
Okay. Perfect.
Yeah, it's okay. Thank you, Sandra. So, as you know, and as we mentioned previously, transition time for Prader Willi syndrome is challenging because of cognitive and psychiatric disorders, emergence of worsening of many comorbidities, and especially hyperphagia, behavioral disorders, and obesity and its related complications. And also because young people with Prader Willi syndrome start to feel the difference between themselves and their peers. Let me sharing with you our data published 3 years ago. We evaluated and compared both endocrine and metabolic parameters of adults with Prader Willi syndrome, depending on the transition status of those who received transition care and those who did not. And we defined transitional care as a specialized pediatric care followed by an organized care pathway to a multidisciplinary adult team. 95 adults with Prader Willi syndrome were included. In the transition group, we had 31 patients, and in the without transition group, 64. The main reasons for the absence of transition, where the disruption in medical follow-up during pediatric care, the late diagnosis of Prader-Willi syndrome for the oldest patients we had, and the lack of specialized pediatric care, and for 2 patients, the refusal of the proposed care pathway by the family. These are the characteristics of the patients with the mean age 29. As you see, BMI almost 40 kilogram per square meter. Almost 50% of them had grade 3 obesity, and also psychiatric treatment, and also hospitalization in psychiatry in the past. So what we observe is that for a patient with transition, we observe the better endocrine management, especially for testing and hormone substitution, for growth hormones, but also for sex hormone therapy, and also metabolic and psychiatric parameters, which were impacted by the transition, with a lower BMI and percentage of fat mass, and better metabolic assessment, and fewer psychiatric treatment for patients with coordinated transition. So we could conclude from these results, and also from our experience, that a coordinated care pathway with specialized pediatric care and transition to a multidisciplinary team for adults, but also accustomed to managing complex disability, improves the health status of adults with Prader-Willi syndrome. I finish I would present you our organization in our reference center for adult, Prader, in Pitié-Salpêtrière in Paris, where the patients from pediatric hospital are admitted by a medical referent, but also supported by the coordinator for transition, who is Sandrine today with me. The care is based on the first evaluation during 1-day hospitalization with a multidisciplinary staff, coordinated both by the medical referent, but also by the coordinator for transition. And this multidisciplinary staff includes social worker, nurse, dietitian, and also physical activity educator. And the follow-up by our reference center depends on the initial diagnosis, the initial evaluation of the complexity of the situation, and it is done by outpatient clinic or 1-day hospitalization, depending on the complexity and the situation, every 6 to 12 months. After that, we can orientate, coordinate also, and teach with the medical staff around the patient, with the general practitioner, and also all specialists. But as we mentioned before with Tony and Maite, the central role of the psychiatrist, and also of the social support with mandatory territorial network, which works with us. So all this, organization needs development of tools and also informative supports for social support, for example, face-to-face meeting between all the staffs for complex situation, and also, of course, the support by a coordinator of transition. And Sandrine will now have an interview. Perhaps, Sandra, could you launch the interview, which is translated because it's in French, but it's translated for you.
Okay, I will launch the video. One moment.
Thank you, Sandra.
Nous sommes dans l'espace d'accueil Transcende de l'Institut Endocrinologie et Métabolisme de l'hôpital Pitié-Salpêtrière, où sont accueillis des jeunes adultes suivis dans le centre de référence syndrome de Prader-Willi et autres obésités de cause rare avec troubles du comportement alimentaire que je coordonne. Bonjour Sandrine, vous êtes coordinatrice de parcours de santé pour ces jeunes. Pouvez-vous vous présenter et nous expliquer ce qu'est un coordonnateur de parcours de santé?
Bonjour professeur Poitou. Je suis Sandrine Botius, donc effectivement je suis coordinatrice de parcours de santé dans le dispositif travaillant sur la transition appelé Transcende. La fonction de coordinateur de parcours de santé est née de la complexité des parcours de santé de personnes souffrant de maladies chroniques, nécessitant l'intervention de multiples spécialités autour d'eux et forcément de l'intervention de professionnels pluridisciplinaires. Le coordinateur de santé a donc pour rôle de renforcer et de créer du lien entre ces professionnels dans le parcours de vie du patient, incluant donc le secteur extra-hospitalier et le secteur intra-hospitalier.
Qu'est-ce qui vous a amené à exercer cette fonction?
Donc, je suis de formation initiale psychomotricienne et c'est la volonté de travailler davantage sur le lien entre les professionnels et aussi l'attrait vers la transversalité dans l'accompagnement en santé qui m'ont mené à la suite de l'obtention de mon master à cette fonction de coordinateur de parcours de santé.
Vous travaillez avec des jeunes adultes en transition. Sandrine, pouvez-vous nous expliquer ce que sont la transition et le programme Transcende développé ici à la Pitié-Salpêtrière?
Bien sûr. Alors la transition est par définition un processus de passage organisé et coordonné des adolescents ou de jeunes adultes présentant un trouble médical chronique d'un système de prise en charge pédiatrique vers un système de prise en charge adulte. Cette période de transition s'accompagne souvent de ruptures liées à l'âge ou aux préoccupations, à l'incertitude aussi dans le projet de vie. Et le risque, c'est bien sûr l'aggravation de la situation de santé du jeune adulte et aussi le risque de patients perdus de vue. L'objectif de notre programme Transcende est de contribuer à la continuité du parcours de soins de jeunes adultes accueillis à la Pitié-Salpêtrière pour le traitement de maladies endocriniennes, afin d'éviter le plus possible l'aggravation de leur situation médicale et bien sûr d'éviter aussi le risque de rupture plus globalement cette fois-ci dans leur parcours de vie.
À quel âge en moyenne vous arrivent les jeunes patients en transition?
Alors en moyenne c'est à l'âge de 19 ans qu'ils nous arrivent. Maintenant notre plus jeune patient a 16 ans et notre plus âgé a 26 ans.
De façon générale, quelles sont vos missions dans ce programme Transcende?
Alors globalement, mon rôle c'est de faciliter le passage entre l'hôpital pédiatrique et l'hôpital adulte. Maintenant, je peux aussi être personne ressource, en plus bien sûr des médecins référents, pour le jeune et pour son entourage, au sein même de l'hôpital. Je veille aussi à la continuité dans le parcours de santé, par le suivi des rendez-vous, et je contribue aussi au lien entre les professionnels du secteur intra et du secteur extra-hospitalier.
Plus spécifiquement, pour les jeunes patients ayant un syndrome de Prader-Willi, que peut leur apporter votre fonction?
Les personnes présentant des troubles neurodéveloppementaux, dont fait partie le syndrome de Prader-Willi, ont effectivement des spécificités dont il faut tenir compte. Par exemple, elles ont besoin de repères plus stables, de réassurance. Or, la période de transition, c'est une période de changement. Donc, elle induit de l'inquiétude, elle induit de l'anxiété et forcément, elle peut augmenter les difficultés comportementales. La rigidité de pensée qu'on peut voir chez certains de ces patients, les différences de niveau de déficit intellectuel, mais aussi les difficultés dans les interactions sociales, demandent à ce que nous adaptions toujours en équipe les supports de communication et aussi d'accompagnement pour les rendre le plus accessibles possible à la fois aux jeunes, mais aussi à son entourage aidant. Je participe par exemple aux sessions d'éducation thérapeutique du patient où sont inclus également les aidants, notamment sur la thématique de l'aventure administrative. Parce que la recherche d'orientation adaptée, la mise en place ou l'accès en tout cas aux aides sont souvent source d'anxiété pour les aidants. Et tant il y a de structures en ville qui sont adaptés, mais dont l'accès peut être complexe. Et dans ces moments-là, le travail avec les travailleurs sociaux est là indispensable. De par le profil comportemental de ces patients, il est important de prendre en compte, bien sûr, la situation familiale et aussi la place des aidants qui est bien sûr primordiale.
Pouvez-vous nous donner un exemple concret d'action de coordination que vous avez menée auprès d'un jeune adulte ayant un syndrome de Prader-Willi récemment?
Oui, donc nous avons reçu un patient âgé de 19 ans souffrant du syndrome de Prader-Willi qui a été donc adressé au centre de référence par un hôpital pédiatrique. En liaison avec la secrétaire médicale, une première consultation en médecine adulte lui a donc été donnée sans délai. Et dans le même temps, j'ai contacté l'hôpital pédiatrique pour justement récupérer les documents nécessaires au passage en service adulte afin que le médecin adulte puisse aussi avoir une vue d'ensemble sur l'histoire pédiatrique du patient. Environ 1 à 2 semaines avant la première consultation, j'ai donc appelé la famille et le patient pour avoir connaissance de l'ensemble des professionnels du secteur médical et social travaillant auprès de lui en dehors de l'hôpital, mais aussi pour recenser leurs besoins en vue de la transition. La demande portait principalement sur un accompagnement administratif, sur aussi la gestion des troubles du comportement alimentaire, comme c'est souvent le cas avec ces profils de patients, et aussi la nécessité de coordination avec le personnel de l'établissement d'accueil de jour qui sera amené ou qui était amené aussi en relais de la famille à accompagner le patient lors de ses rendez-vous médicaux. J'ai reçu le patient, sa mère et son éducatrice juste avant la première consultation médicale adulte pour faire connaissance et établir aussi une relation de confiance et aussi pour faire le point sur la situation, leur expliquer le fonctionnement des visites à l'hôpital et leur faire visiter les lieux stratégiques pour eux. À la suite de cela, en termes d'action de coordination, et j'insiste toujours sur le travail vraiment pluridisciplinaire, j'ai accompagné ce jeune et son entourage sur le suivi et le rappel des rendez-vous médicaux, aussi pour bien sûr éviter au maximum les ruptures dans le parcours. J'ai contribué aussi pour une meilleure organisation dans son parcours au regroupement du suivi médical sur un seul et même hôpital pour éviter aussi les allers-retours. J'ai contribué à la mise en relation, la mise en liaison de la famille avec l'assistante sociale du service et aussi avec nos partenaires associatifs pour les aider dans la démarche administrative, notamment au sujet de l'orientation professionnelle, mais aussi l'hébergement, les loisirs. Pour la suite, mon rôle sera de suivre l'évolution de ce jeune pour les prochaines années, afin de m'assurer que son suivi médical se poursuive, que le lien aussi avec les structures d'accompagnement à l'extérieur de l'hôpital soit maintenu et de permettre, si besoin, la formation de ces structures aux spécificités de ce syndrome. L'objectif est qu'il existe une cohérence d'accompagnement entre tous les acteurs, tant au niveau médical qu'au niveau social et environnemental, dans la considération perpétuelle du parcours de soins inclus dans le parcours de santé du patient, lui-même constitutif du parcours de vie.
Merci Sandrine.
Merci à vous, professeur Poitou.
Okay. Sandrine is with me. If we have some question, we can try to answer. I look at the question box. We do not have any question.
No.
Okay. So perhaps we can.
I have one question for Sandrine or for you, Christine. How many patients did you follow in the Transcend? How many patients with PWS did you follow with the Transcend structure?
Yeah. So for the total number of patients, because Sandrine is the coordinator of transition for all the endocrinological diseases, I think it's Can you 750 for all the cohort of Transcend, for all the rare endocrinological diseases in the different departments of our hospital. But for Prader Willi, our adult cohort is 130, but in Transcend, I suppose it's perhaps half of them, 60. 64 has been included for 5 years now. For 5 years.
5 years.
5 years, yes. Okay. So 64 subjects with Prader Willi, adolescents with Prader Willi, young adults with Prader Willi for 5 years.
You see, there's a question in the inbox from Anna. And the question is the role of PET transistor coordinator specific for Prader Willi syndrome, or is it something that is common for other pathologies as well?
Yeah, Sandrine explained in the movie that some common action are destinated to all the patients in the transition, but we have also specificities for Prader Willi, like other rare genetic obesity with neurodevelopmental disorder, with a lot of actions based on coordination of social support, and also all the issues with worsening of behavioral aspects, and also reassurance, trust in the team, because they need really reference and referent to be less anxious during this transition. So we have also specificities with Prader Willi, yes.
Christine, there's another question. Tony, in the chat box, so not in the question box, he's asking, how do you support people with PWS living a long way from major centers, particularly if they have a crisis?
Yeah, we try to work with psychiatrists, actually, with a team involved in management of behavioral crisis, but it's difficult. I think it's the main issue during the transition, and the problem of behavioral crisis in the living home. So we have perhaps every day phone call for this sort of problems. We have also support from territorial network, with a team involved in disability, and so they can also do the link between hospital and living places. Yeah. Okay.
Did you see an improvement in the transition since you started to Transcend for these people?
And
it's
what
a good
kind
question. Of improvement?
Yeah, of course, it's a good question, Maite, because we do not have evaluation with a control group and a group with Transcend. All our patients are included in the program, so we have to evaluate this very precisely. But from my experience before and after Transcend, as a physician, as a medical reference, I see really a huge improvement in the trust the patient can give to the team, and also yes, the role of Sandrine is really important with the link with the social network and the sector outside hospital. I see really from my side changes for 5 years now that Transcend has been implemented here at hospital. Yeah. But you're right. It's an important point we have to evaluate. Yeah.
Thank you both of you for this very challenging point. I think it's something that to be evaluated and see if it can be implemented in many other centers.
Yeah.
We need to now to give places to patients and parents' view and to have time to listening to them. And I am very pleased to introduce Berit Otterleit from Norway, with whom I had the pleasure to talk for preparing this intervention. And I think it's very important to have the voices of the parents and the patient's view. So we will have first the parents' view with Berit Otterleit from Norway, and then the patient's view. And the patient was the movie was arranged by Anita Oken-Kollega team. So we will start with Berit. Berit, you can start.
Yes, can you hear me?
Yes, we hear you.
Yes, perfect.
And we
thank
see
you
the
very
slide.
much. Yes, thank you very much. First and foremost, I just want to say thanks for giving me this opportunity to say a few words. But first of all, I want to really thank everyone that has been presenting until now. On behalf of every parent with or patients with Prader Willi syndrome, because it's really nice to see all the good work and all the research and the work that is being done to improve the lives for everyone with Prader Willi syndrome. So thank you very much. It's really important, and you're doing a really important work. So, okay. You can see my screen, and I have called named my speech. Thank you for listening, and I will explain why a little bit later. So I'm coming from Norway. I'm what we call an EPAG, a patient representative in the Endo-ERN network. In Norway, I have been an active member in the Prader Willi organization in Norway for 23 years. For 10 years, also seated at the national board, and I'm also seated at the board of Frambu, which is a national resource center for more than 400 rare diseases in Norway. So that's just a short introduction. You can hear that I'm not a native English speaker, but I'll do my best. So I try to move the slide, and somehow it stops. There. Just a quick overview of what I'm going to talk about. And I said something about the ethics, because I have been going through this presentation with my daughter, which I'm going to present a little bit more. It's just a shortcut of some points where I think it's important to talk about. It's not our complete story, and also some details that she didn't want me to talk about. So that's the ethics behind. I just wanted to say it to you. So a little bit about the background. So I'm a parent, and on the the little baby you can see on the side here is my daughter Mari, that was born in 1998. So she is 23 years old, and she was diagnosed. I think I can say that she has like she was born with a lot of classical PWS features. She was 1 month old when we got the diagnosis, and I'm really happy that we got it so early. She has a deletion type. I know that many people are wondering when they are hearing about certain patients with Prader Willi syndrome. She was like a floppy baby, hypotonic, and she used a feeding tube until she was 4 months. She walked when she was 3 years. She started with growth hormones when she was 7 years, and we have had strict food control all the time because we learned about the syndrome. So she haven't been obese during her lifetime. She also have reflux and a mild cognitive disability. And for 2 years, last year she also got Graves' disease. I'm going to talk a little bit about that later. The pictures you see is just a family picture. She is born in, I'm married, and we have 3 children. So Mari is in the middle one, and I also have a son-in-law that's on the picture here. Also a picture here with Mari and her training partner at the first gym session after the COVID lockdown in Norway. They were really happy to start training again. She's training a lot and likes it very much. And the last picture here is, can you see? I hope you see the picture.
Yes, we can see it, Berit. Thank you.
Okay, yes, because I have yes. And there she is. Have moved out just 5-6 weeks ago. She moved out to her own flat, of course, in a sheltered home with help and everything. And she is working full time at a sheltered workplace at the laundry. So that's just a picture from her, and a text that says everything is going perfect. This is going perfect from her work leader that has sent me a snap from her work. So just to put her in the picture, so you see a little bit who she is. So I wanted to say a little bit about going from childhood to adolescence. In the physical way and in also this psychological way. I take that afterwards. So about the physics, I want to mention, you have been several of you have been mentioned a lot of things that I'm going to say. So, but that's good. I tell it from my perspective. I would say that a little bit about the puberty from the normal versus the PWS puberty, because she started showing some signs for the puberty, but at the level it stopped. It just she couldn't pull through, and she didn't get the menstruation, and also a lot of the physical features just stopped at the level. And then I wanted to say that me and my husband went to Taiwan at the World Congress for the IPSO organization in 2010, and then she was 12 years old. And some doctor gave a lecture then and talked about giving the women, the young teenager women with Prader Willi syndrome, the possibility to going through a normal puberty and with all the features. If I haven't heard that lecture, I wouldn't thought it would have been so important. So I was so lucky. I also so happy that I have heard that lecture, and that gave us some argument with the doctor to give her hormones so that she got the menstruation, and also we saw that her body changed in many ways. And that's also why I put out the picture here, because the picture here is of my daughter Mari with the Prader Willi syndrome, and also her sister who is 3 years older. And I saw that this was also important for the sisterhood between them, that they could relate to each other, talk about how going from a girl to being a woman, And she also gave some comments about in the gym at school, that she liked looking like the other girls at school. So I just wanted to say that that's our experience about these physical things about puberty. I just wanted to say about the medical treatment that she has been using. She is using growth hormone. She's using medicine because she has reflux, and she has for almost a year has been taking medical some treatment because she has Graves' disease. Yes, and that comparison with others is what I just said, that it is normal in every teenager's stages to start in a more to compare yourself with others, and my experience is that the Prader Willis do too. So I think it's been important that she can be as like as the other as possible. That has been our approach to it. So let me go further. So this is psychological way. Many things has been said before, and I'll tell it in our way. Of course, we have there have been several issues that we have been thinking about, how mentally prepare her to be a grown-up, how will adolescence be for her, how independent can she be, what is okay or not, and also the preparation to moving out. I wanted to tell a short story about adolescence, because when she was only 9 years old, I told her about motherhood and not be able to be a mother as a grown-up. It's very early at 9 years old, but she has been talking so much about it, of being a mom, playing with dolls, and talking, said a lot of things about it. So I thought that I just need to tell her about that it could be really hard to be a mommy when you have Prader Willi syndrome, and it might not be for her to be a mommy. And the reaction was really spontaneous and big. She cried. She really cried. She was only 9, and I didn't think she would understand so much of it, but she really did. And it was really tough. It was a tough conversation, and it was tough afterwards. But the reason I'm telling this is because just I think 2 or 3 weeks later, there was on a field trip with the school. And some of the other kids had parents that had been reading on internet about Prader Willi syndrome, and somehow some of the kids had got the information that when you have Prader Willi syndrome, you can't become a mommy. And they told her on that field trip, "Oh, we have said and heard that you can't be a mommy when you grow up." And I was so glad that I have told her for myself, that it was not for anyone else to tell. So I think it's important that for you, many of you are doctors or therapists that meets parents, just encourage that it is smart to talk about it in early ages, because the information goes around everywhere. So if the parents wants to be the one to tell them, then they should do it as early as that is okay. So independence. There are many things that is not easy to be independent in Prader Willi syndrome. The way we have looked at it as parent is that how we want her to be as independent as possible in the issues that she can be independent in. It's not easy. It has been difficult, and I wanted both with the food, with socially, And I just want to say, put out one thing that has been a lesson for us. She has had a few boyfriends, and a few years ago she had a boyfriend that was in a different way than the other ones. And we started to think about and also trying to talk a little bit to her about sexual education and so. And we saw that there was a lot of things that she didn't know so much about, and we wanted to protect her. So we went to the hospital, to the therapists there, and she got a sexual evaluation. They took like a screening of her, talked to her, and went through like a lot of schemes and came with a conclusion in that I want to refer to here. And then she was offered group sessions afterwards to learn more about these issues. She didn't want to talk about this in groups. She didn't want to take that group session thing. And I can understand her in many ways. I wouldn't have discussed my sex life in a group, me either. So I really understand her. So, but she was then offered individual education, yes. So she have weekly appointments now in locally where we live, with a teacher, learning about anatomy and physiology and how the body works, and also some social things around being a teenager grown up. Yes. It has been a good experience, and I think it's really important to learn these things. For me, that is I think that will help her taking more care of herself. Of course, we as parents are also taking care of her, but also that she can take care of herself. She needs knowledge to do that. Yes, I think I see that the clock is just moving fast, so I think about moving out, I want to say that we have been talking about moving out with her for many years, that it is normal to move out in our community and the social surrounding. It's normal to move out when you are about 20, early in the 20th. And we have been talking to her about it, preparing her, and when she moved out 5 weeks ago, it was she that really wanted to move out, because I'm working on building a group home for her and 9 others, young people with disabilities, but she has not got the time to wait, so she wanted to move out, and she's really happy. It's tough and challenging, but this is what she wants, and I think that's because we have prepared her for several years about it. So let me see. Next slide. This is also I think it's really important, and Tony, you were talking a little bit about it earlier. The symptoms not symptoms, this is diagnosis. My daughter doesn't have these diagnoses, I just want to tell you, but she has for 2 periods the last years shown a lot of symptoms of these diagnoses, as you see here. For 2 period of time, she showed the same symptoms. Really depressed, everything was wrong in her life. She has really severe sleeping problems. The anxiety level just getting through the roof. She was almost paranoid in many things, and also very emotional sensitive. Like we couldn't say anything, and she just started to cry and was afraid and sad and everything. The first time, and in the both ways, we have learned earlier that when they show when the mood changes and then they're showing a different way of acting, we should not only think that it was something physical wrong, that we should or psychiatric things that were wrong, but we should also look to the environment. I've heard that in speeches many times, lectures earlier, and I was so glad that I've heard that, because we started in the first situation, we started to look through her environment at work, with a boyfriend, at home, and we saw a lot of things that was not okay, and it hasn't been for a long time. So and we also took her to the doctor, of course, to just take an evaluation. Is there anything that you can think of that is wrong? Took some blood samples, something, and with the doctors everything was okay. But when we started to clean up the environment at home, at work, with her boyfriend, it just in 14 days, everything, not everything, but many things fell into places, and she was getting, after a while, she was getting back to normal. It was just so not predictable. The environment was not so predictable. There was some chaotic things changing at the workplace. The boyfriend, there were several things that was not okay. So that's causing all these symptoms. Then almost 2 years later, she showed the same symptoms again. It started up again with almost the same, completely the same symptoms. This time too, we checked with the work. We thought about everything at home, the social things. Of course, we talked to her about it. We couldn't find many things to clean up then. And this time too, we went to the doctor, and then she got to diagnose Graves' disease. So what I wanted to say these things is because they can show same symptoms with two totally different outcomes. And otherwise I can't go through that, but in another case they can show almost any symptoms and have a disease. So what I have written down here: never trust the symptoms or the lack of symptoms. You can't always trust the normal symptoms. Of course, many of you have met many Prader Willi patients and you know these things, but I just wanted to underline it because that's our experience too. So what have it, and I'm almost ready now. So what has been most important to us dealing with the Prader Willi syndrome for 23 years? I think that the knowledge about Prader Willi syndrome and what's coming up next has been really important for us, both at the national level, from the National Resource Center Frambu. That's why I put down the logos down here. So Frambu has been really important for us to have the knowledge about Prader Willi syndrome, and also the international congresses and all the brochures and the website, and everything has been really important for us. And also knowing other parents, a really important thing to know other parents in these issues. The knowledge of where to go with what has been really important, and that's not easy to know where to go with what. I have been working for myself in the healthcare system, so I know a little bit more than other parents, but that don't work there. But it hasn't been easy. But what I have been knowing has been made things easier for us. And then the last thing I've written down here is doctors that are listening, because we almost never meet doctors that are known with Prader Willi syndrome. Almost every time when we go to the doctor, my daughter is the only patient they have with Prader Willi syndrome. So it has been really important that the doctor has been listening to what we as parents know about Prader Willi syndrome. And our experience is that when they listen, they do something. When they listen and they act on it and do something. Because they contact the people that knows. So that's why it's important to listen. So let me see, and wishes for the future. I wish that every family with Prader Willi syndrome are connected with other families, and I know that many of doctors are helping the families with that, and keep on doing that. You just have to you need a consent, of course, but please just continue that work because it's so important. I wish for healthcare pathways for Prader Willi syndrome that could be easier it could be easier to just come in and everyone knows what to do. It's a big wish with a rare disease, but I can wish for it. And also possibilities for every PWS patient to meet doctors that have met other peoples with patients with Prader Willi syndrome. I really wish that could be possible for a lot more patients than today. And also clear guidelines that includes both the healthcare system, social care system, schools, and workplace. And it was really nice to see the video from France. It was like a dream world. It looks so nice, that program, that would have been really helpful, I think, for me and for many others. I know it would have been. So thank you for listening today. Thank you for signing in on this webinar and to getting more knowledge about Prader Willi syndrome. Thank you for that you are, as a doctor or therapist or anything, that you are listening to patient and parents or other people around the patient, because I know you do, many of you, and also listening to studies, other doctors and everyone who knows something about Prader Willi syndrome. It's really important that you are listening. Because I know when you are listening, let me see, because I know when you are listening, I know that many things can be possible. That's our experience from meeting with the doctors, that the ones that are listening are also acting and making things possible. That's why my daughter can climb in the mountains, because we have got the knowledge to do what she needs to do, can be able to do that. So, okay, thank you. I think that I have to stop there. Thank you so much.
Thank you, Berit. Perhaps we will move immediately to see the video, if Sandra can put the video in, and then we will have a discussion and the final conclusions.
Yeah, I will launch the video. Thank you.
Okay.
We zijn hier op Hoeve-Biesland en ik werk hier 4,5 dag tot 5 dagen. De boerderij ligt hier tussen Delft-Gouw, Noodorp, Pijnacker en Delft. Lekker in de open natuur, dat is fijn.
Bella even gedag moet zeggen.
Ja.
Hoeve-Biesland is eigenlijk een multifunctionele boerderij. Dat betekent dat je hier niet alleen een veehouderij hebt, maar dat we hier ook een winkel hebben, dat we hier een slagerij hebben en een bakkerij. En hulpboeren, dat zijn eigenlijk mensen die tijdelijk of permanent eigenlijk niet mee kunnen in de maatschappij, maar hier een plek vinden, zeg maar, om hier te zijn.
Het verzorgen van de koeien, het voeren, het verzorgen dat alles schoon is, de kalfjes en de mes schuiven.
Ja, nou, Maxi kan heel goed zelfstandig werken. Hij voelt zich verantwoordelijk voor een taak, heel erg verantwoordelijk zelfs. En voor de rest is het gewoon een fijne jongen om in de groep te hebben.
Max is een man van 27 jaar. Onze zoon. Een hele mooie, slanke, lieve, vrolijke en opgewekte jongen.
Ik wandel heel veel samen met hem, met de hond. Dat is dan voor hem ook een moment waarin hij vertelt over wat hij meemaakt. En dan halverwege zijn wandeling kan hij altijd zijn arm om me heen leggen. En dan helemaal laten voelen hoe blij hij is. En ook echt zeggen van hoe fijn hij het vindt om met me te praten. En nou, daar ben ik dan altijd heel erg van onder de indruk. Max heeft hulp nodig met plannen. Daar moet je heel duidelijk over zijn als je iets wilt. Je wilt over 10 minuten de deur uit. Dan moet je toch eigenlijk wel zeggen welke handelingen hij moet verrichten om de deur uit te kunnen.
Max die rijdt in de normale lessen. En in het begin heeft hij wat extra privélessen gehad omdat hij wat meer aandacht nodig had, met name voor zijn houding en zijn zit. Dat gaat op het moment heel goed. Ik vind heel goed dat Max heeft echt een heel goed doorzettingsvermogen. Want als iets niet lukt, nee, je ziet het al, dan neemt hij extra lessen en dan gaat hij er echt voor. Soms wat ik wel heb, hij is soms zo overtuigend van zijn zaak dat we een beetje moeten remmen. Omdat paarden daar soms een beetje druk van worden. Maar hij laat zich wel heel goed sturen.
Op een normale doordeweekse dag, als hij bijvoorbeeld aan het werk is geweest op de boerderij. En dan is dat ook eigenlijk wel weer genoeg voor hem. Dan is het 's avonds zien we hem eigenlijk niet meer. Dan zit hij op zijn kamer en dan doet hij zijn eigen ding. En dan is hij helemaal blij.
Ik kan bepaalde dingen iets minder goed dan in fysieke kracht. Dat kan ik wat minder.
En je merkt ook dat hij juist door dat hij dingen zelfstandig mag doen, dat hij veel meer zelfvertrouwen krijgt in zichzelf. Dus hij komt hier elke dag met een grote smile naar zijn werk toe. En ja, hij is hier graag.
Ik ben ontzettend trots dat hij zoveel dingen zelfstandig kan. Hoe blij hij is op zijn werk, hoe hij daar op zijn plek is, hoe vertrouwd hij zich daar voelt. Ja, dan ben ik trots dat we dat voor elkaar hebben gekregen, dat zijn omgeving blij met hem is.
Een van de dingen die bij Max belangrijk zijn, hoe om te gaan met veranderingen. En als je die tijd nou maar geeft en ook duidelijk naar hem bent, het heeft geen haast, maar denk er eens over na, dan komt het eigenlijk bijna altijd wel goed.
Nou, Max komt hier regelmatig op bezoek. Dan stapt hij zelf op de trein. Dat hebben we een aantal keer geoefend en dat kan hij nu helemaal zelf. En dan haal ik hem op het station en dan gaan we naar huis. En dan gaan we samen eigenlijk bedenken wat voor dingen we kunnen gaan doen. Hij is heel lief en zorgzaam, maar helemaal op zijn eigen manier. Een manier die hem heel erg past. Wat ik altijd heel bijzonder vind aan Max is dat hij nooit een oordeel heeft over iemand. Ik denk dat Max het onwijs naar zijn zin heeft in het dagelijks leven. Hij gaat naar de boerderij, hij rijdt paard, hij gaat naar Aikido. Hij heeft het daar naar zijn zin met alle mensen die hij tegenkomt. Hij is over het algemeen altijd vrolijk als hij thuis komt. Dus ik denk dat hij, ondanks alles alle lastige dingen die hij tegenkomt, dat hij toch heel gelukkig is.
Thank you. Thank you for these two presentation, the presentation and the video. As we can see, if we have some question, I don't see the questions, Sandra. I don't know why.
Yeah, look
Perhaps
at
Christine, you have some
box.
questions?
Yes, I look at the box, but no concern.
I don't see any new ones.
No.
So perhaps what we have seen in these two presentations is that it is possible to have a life, you know, with some very nice things and daily life, which seems to be really really good for the patients and for the families. And so it's something that we have to work on to make all patients having this possibility, if it is possible, of course. It clearly depends on the persons and the environment, the care, and so the work of every of us. So perhaps to make the conclusion, I will leave the door to the scene to Christine. Christine, if you can start to comment the slide.
Just a short summarize for what I see. It's important to me after this varied and complementary views of the transition we have seen this afternoon. The transition of care in Prader Willi syndrome, that means a comprehensive care of complex situation in a challenging period, with a multidisciplinary physical approach with different medical specialists who are involved, with the endocrinologist who has the central role, but also behavioral and psychological dimensions that need for psychiatrists or psychologists trained in Prader-Willi specificities and involved in the transition. And as you propose, Maite, perhaps psychiatrists or psychologists really a coordinator of the transition. It's an idea to improve yes, this difficult transition in psychological dimension. Also, need for evaluation of psychological impact for the caregiver and especially for the parents. We heard Berit on how the importance of guidance of parents is really important, and the listening of parents and also patients, and also the importance of social support with, as I said, educational and vocational guidance of patients and parents, how we can improve living arrangement and also deal with the vulnerability protection, and the needs or multidisciplinarity around the medical staff and also coordination of the care pathway. I think it's really important to coordinate all these different aspects. So just here I mentioned the work which has been coordinated by Maite in France, and an updating of the guidelines, the French guidelines for care and diagnosis and care for Prader-Willi syndrome at all ages. We had a question from an attendee, which clinical guidelines would you recommend using for management Prader-Willi syndrome in children and adolescents? I think this really complete work from France is, I think, very important support and for all the guidelines we could communicate and perhaps yes, translate in at the European level in several languages. So yes, if we can conclude with all this complementary dimension, I think it's good. Maite, I let you the last perhaps word and conclusion.
Thank you, Christine. It will be very, very short, and I think you summarized very well all the issues that we discussed today. I think the overview given by the speakers were of high quality, particularly listening to each other, first listening patients and parents and listening to each other, sharing the difficulties, solutions, strategy, new ideas, new concepts. I think it's a way to go ahead. And perhaps early treatment may modify the course of the disease. We don't know, but it's still very important to do. So with that, I think every speaker, every participant, and Sandra, who had prepared that with us, and of course, I thank Christine to share with me this very interesting webinar. And I thank the whole group of MTG5 that invite us to make this symposium. So have a good evening, and thank you to everybody.